presenter, correct?
Yeah.
And the title of your presentation sounds very exciting. Novel Simulations of Ablation Procedures, a journey into virtual hearts with real catheter.
Yeah, that is what is the topic of the next talk, and it is really fascinating what today we can do, and so let's show me a little bit and share our experience in that field. So the nice thing is that you have real catheters that you hold in your hands, and you go into virtual hearts which are only there in the computer. So what we see here is there is arrhythmias are increasing because of the aging of population, and you see here the increase for atrial fibrillation. So there is a need for more interventions in the future, and so we also need to train more of doctors to become electrophysiologists. And so the next generation can benefit from simulators that can speed up the learning curve dramatically. So the current way of teaching new electrophysiologists by a mentor, teacher, and the trainee is looking how he does it, and then he takes over. I think this goes with some risk for the patient sometimes. There will be more radiation time if you do that. So to have like a first phase where you would train in virtual hearts of real patients, that could be beneficial. So it could speed up the learning process, is increasing the safety of the patient, and you can establish your procedure so that you are quite fast and efficient if you do it in the real patient. So I think pilots, they will never do their job without simulations. For them, it's of course the usual thing to do, and I think we should start doing that as well. So this is a nice objective, to train the next generation of electrophysiologists and to develop this platform for training the next electrophysiologists, and also to give them different complexities of hearts. Yeah, this is supported by industry. It's mainly driven by ADIS, which is a spin-off of the Federal Institute of Technology of Switzerland. So it builds up of several parts. So one part is called Hearts. This is AI-based software. It can automatically segment the heart, and it can also detect analyzed scar tissue and see and look for slow conducting channels in the scar tissue, so that it could guide us where to burn. So Hearts has some subunits. So there is the ScarNet, for example, here, where you can integrate into the mesh of the 3D anatomical heart. You can add the ScarNet, you can add the distribution of scars here. Then is the HeartNet that will add the function to that 3D heart. And then the EpiNet is the electrophysiological net that will add electrophysiological information into this heart. So at the end, you will get everything in one heart. You get the anatomy, you get the function, you get the scar as the substrate for arrhythmias, and you get then the excitation during, for example, re-entry tachycardias. And then there is ArtSim. So this is the AR, also augmented reality-based simulator that you can use for training or also for preparation of complex procedures. So Hearts then, with all these features here, connects to the simulator and feeds the information into the simulator. At the moment, we have the 3D mesh here in 3D. We can add scar. This is in progress now, and this is also in progress. So the next step, based on our quite large grant from the Swiss National Science Foundation, will cover this part. And then if this is done, which is already quite advanced, we will go to this one. But I can show you a few examples of both of them. And then there is the integration of this simulator into the scanner hardware, into the scanner. So the simulator can be coupled to the MR environment. So in fact, this information which sits in the simulator will also sit in North Star in the near future. So what you see here, what you see in the simulator, you will also see in North Star. Then this is coupled to the MR machine here. And then you have a seamless transition from acquiring data in the patient in a non-invasive way, like 2, 3, 4 weeks before the intervention. Then you can train yourself, if you want, on that specific patient to try which ablation procedure will be the best one. If you know, all this information will be coupled to the MR machine, and you do on the same data the intervention in the real patient. So this is Udaranga. He is here today, so he will tell you afterwards a little bit what was the challenges, some of the challenges by developing this AI-based interfaces. This is a short movie, what you do in the simulator. And you can go here in the heart to these points. You see here the flutter and different orientations. You see here the force. F means the force. So it calculates the pressure of the catheter against the wall. So you know that you should be about more than 3 grams, not higher than 30 grams. So 13 is a good value. If you have a certain time, 13, then you go for a good ablation. And the simulator gives you metrics as output. So you can program the simulator, and you can use the simulator to give you, for example, the time when you enter the right atrium until you enter the coronary sinus. So this time to coronary sinus cannulation can be taken as seconds, as a measure of your ability to steer the catheter, manipulate this catheter. So here we're clearly testing the skills of how to manipulate the catheter, how to drive it into, put it into the coronary sinus. You can also then look for example, duration of ablation points. So if you put the catheter on the point, you must be within, for example, 3 millimeters of that point. You have to be there with a pressure higher than 3 grams, not higher than 30 grams. And you must be on the point for 30 seconds. Then the point is ablated successfully. So you have 3 conditions. You have 5 points. And if you have done all 5 points with the right conditions, you have done a complete line that shows that you can go with the catheter tip to the exact position. You can be stable at that position, and you can apply a certain pressure at that position over 30 seconds or 20 seconds, whatever you program. And then you can also follow the tip of the catheter, the distance, the trajectory in a distance. So how directly you go to the point, or if you want to go to the tricuspid isthmus line, whether you go first into the right into the pulmonary vein or something in the superior vena cava and so on. So you can use that as a measure of your skills, and also the force is more a measure of safety. If you are not safe, you have too high pressure. So what we measure is the handling of the ablation catheter with metrics, output metrics for performance and safety. So we can apply that for the coronary sinus, and we can apply that to the CTI ablation to create a line in the tricuspid isthmus. So we did a study on that. So we could recruit in our hospital 5 non-electrophysiologists. So these are cardiologists, but not trained in any way to handle catheters. And we could recruit 4 well-trained, well-experienced electrophysiologists doing the same thing. So we started here with 5 hearts. So they had no contact with the simulator before. They had a half-an-hour instruction how to use the simulator, and you will see Nora Bacher. She was the leading person of this project, so she trained and explained how to use the simulator for half an hour. Etienne gave some instructions how to rotate and manipulate the catheter, and then they tried to do an ablation. These 5 non-electrophysiologists and 5 trained electrophysiologists. And then we recorded all the output data, safety parameters, and the performance parameters. Then we gave them 5 different hearts, 15 different hearts with different ablation lines, so they could train themselves on these 15 hearts. And then we gave them in different orders the same 5 hearts again, and we compared these output measures here with the output measures, performance measures here. And we want to see whether the electrophysiologists, whether they improve, and particularly whether the non-electrophysiologists improved. And we put here like 5 hearts, the first five hearts, and then the 15 adding hearts. So they have like 20 hearts to train, and we decided to give them 20 hearts, because we saw from the Leipzig study that about 12 hearts or so, 15 hearts give you a stable performance for electrophysiologists. So we said, okay, we will not be so close to reality. We give them 20 hearts to train. And what we found is here, coronary sinus intubation, and you see here the non-electrophysiologists, the blue bars. They start with 150 seconds mean to get the coronary sinus, the catheter into the coronary sinus. So it's the real catheter that is used in patients, and you put that into the hearts of real patients, but they are displayed in a virtual environment. So to put the catheter inside, 150 electrophysiologists, they were much faster. And after 20 hearts of training, they significantly improved the non-electrophysiologists. The electrophysiologists, they were about the same. They did not improve. It's too easy for them to do that. So no improvement for them in the time for cannulation. And they needed about 55 seconds on average to go into the coronary sinus in the simulator, 55 seconds. We also looked at the catheter tip distance, and it's a very similar information. So they had 3,000 millimeters of going up and down and back and forth in the atria to find the coronary sinus. Finally, they found it. They put the catheter into the coronary sinus, and they had to be at a certain point in the coronary sinus, which is marked with a sphere. And they had to stay there for, I think, 10 seconds to give the simulator the confirmation that they cannulated correctly the coronary sinus. So they improved significantly after 20 hearts. No significant difference for the electrophysiologists. And so here you go through to these points, and you see the force should be more than 3 grams, stability 5 seconds, and safety, 50 grams finally was set as the safety limits for these interventions. And then, as I explained, these 5 first different hearts, then 15 hearts for training, and the 5 hearts again here. And this is a trajectory of a beginner, of a cardiologist without any skills to manipulate the catheter. And you see he wants to go to these points, but he goes everywhere, even into the right ventricle and up into the pulmonary, in the outflow tract and superior vena cava, everywhere. And he could do that 20 times. And you see what he's doing then. He goes once into the ventricle, a little bit up here, then he bends down and goes down and finds the point. So you see nicely here what training can do with a cardiologist. Then we look for catheter tip distance for the ablation, and you see again here what you saw in the graphic before. This mimics or puts that into statistics here, that the non-electrophysiologists, they were much longer in the distance than the electrophysiologists, and they dramatically improved after 20 hertz. And the electrophysiologists, they also improved a little bit, but very slightly, a few millimeters less in distance they did to get to the points. Time of ablation, again, same picture. The non-electrophysiologists, they improved dramatically. They were 2.7 times faster to get the same points after training. The electrophysiologists, they improved a little bit. This is the safety evaluation. So contacts with the wall with more than 50 grams. And you see they had a lot of contacts. Then they went down to very few contacts. And the electrophysiologists, they were safe, but also improved in numbers, but not significantly with statistics. So at the end, it was very interesting to see that the non-electrophysiologists, they were at very comparable levels for this relatively simple procedure. And yeah, I want to say here that here we only tested the skills to manipulate the catheter. So there is no interpretation of ECGs, when you want to burn, because you would be in the ventricular. So they were guided to go to the correct line. They did not need to find the line by themselves. It's only testing the manipulation of the catheter, getting to a certain point and push there with the right force for a certain amount of time and to go into the coronary sinus. But with these manipulation procedures, at the end, the non-electrophysiologists, they were not different from the experienced electrophysiologists. So what you see, and we will show you that afterwards in the simulator, which is just next to us. I will show you a few manipulations on the simulator, just that you get a feeling how it looks like in real. This is the display of the simulator, so you can create scenarios like tricuspid isthmus ablation, pulmonary vein ablation, right atrial mapping, and so on. So you can also, we have also this for ventricular ablation procedures. So you can decide what you want to offer. You can go for easy hearts or difficult hearts, and you can also add complications, so that after the 5th point there will be a problem. You can show a blood pressure that goes down, and you have to know what to do. So this anatomy is reconstructed by the help of AI models. So there is an accurate shape of scar tissue, and this is visualized in 3D and can be overlaid of the 3D mesh of the heart. And of course, we would like to see conduction channels, and we are working on that with some new techniques for super resolution to get resolution which is higher than through plane pixel size. So it's a new technique which will be implemented in the next version of the simulator. And these are parts of the hearts module, so diagnostic model and finding the conduction pathways. And we want also to simulate the EP electrophysiology activity, so the excitation of the myocardium. And this is then what you can do with the simulator. You see here the segmentation of the heart, which is done within a few seconds if you load this. And you can change the transparency of these meshes, and you can add scar information to these meshes. And this is what you then will also see during interventions. So you don't need to change the visualization. You are used to see the same thing again. And this is something that we want to do So here you see an excitation that starts here and propagates. It is a lot of computation times to get this simulation done, and to have such a movie for two hearts. And now the idea is from Addis that we have several of such hearts, also with scar inside, and we train an AI on these models so that these models can be calculated much faster, because the AI will not calculate the ion transports and the contractile forces and the distribution of fibers, but it will learn directly from the output of the model. So it could potentially be much faster. This is what hearts can do now. So it does an automatic analysis of the scar distribution in the wall. And you see here dense scar, and then you see here this gray zone of scars. The gray zone is often at the surface of the scar, but it can also go into the scar. And gray zones here in the scar are probably the substrate of these low conducting channels. So if we see gray zones within here, the heart, you see this is a gray zone that is connected here. It goes in and goes through the tissue, through the scar. Then if gray zone material is connected, forming a channel in the scar, this is assumed to be a slow conducting channel. So we can then calculate candidates for slow conducting channels that would be the substrate for VT, reentry VTs. And then we can display these slow conducting channels, and with different tools you can take away this level here, so you can look inside. And if you see this information in the future, you know where to burn, because you would say, I want to burn here, or I want to burn on this point here. And this is now in a scar. So this model has a scar inside, and we run again these AI-based simulations. And now you see that there is a reentry tachycardia. There is an exit point here, and it starts to activate the whole heart again and again. It's very nice. So it starts with a few normal excitations. So you can artificially excite this model. And then if you pace faster at a faster rate, and then you see that the excitation comes out here. And then it starts to turn around the scar. And if this idea that AI learn from AI, then you would be able to do that during the intervention. That means if you burn here, you can simulate what happens. Are there other channels that are active if you burn here? And you can do that beforehand as well. You can run that before the patient is in the magnet. Then you see that there is an exit point here. Then you can say, okay, I burn here, and I run the model again, and then I may see maybe tachycardia going through another exit point. So we can check beforehand where would be channels based on anatomy on this gray zone, and then we can also add electrophysiological modeling to detect more channels, because there is a nice paper from Trajanova's group, which does such modeling as well, that they found about 30% of the reentry tachycardias are not based on slow conducting channels in tissue, but are like functional conducting channels, which cannot be seen with anatomy, but could be calculated here. We also did a study with the Trajanova group in Johns Hopkins, and they used our MR high-resolution late enhancement data, and they could show we saw more channels delineated on such activated maps if you have a higher spatial resolution. So still high spatial resolution of late enhancement images is very important to detect channels. And then what we also want to do is here that we have this heart that now deforms. In the past or in the current North Star and in the current simulator, when you do the training, they train and they do the ablations on static meshes, but we want to get the heart then beating, and then you have to burn during contractions of the heart, which makes the task for the interventionalist probably more difficult, but also more realistic. So this is the BeatNet element of the heart's software. So I think this could represent a quite realistic simulation for training of future electrophysiologists. It adds 3D navigation in real time. You can also measure forces against the wall, so you can assess the skills with regarding the efficacy, but also regarding safety, what you do. It can be used to establish roadmaps before you do a patient. So patients with difficult anatomies, you can load such a patient, also for example with congenital abnormalities or just difficult anatomies of a given patient. You can load that in the simulator, and you can do this ablation several times before the patient goes into the MR machine. And there are metrics that are presented so that you can assess the steerability and the trajectory, the safety, based on true numbers. So you can compare with quantitative measures the performance of the trainee. So this is what we can do with the simulator today, and there are a lot of very interesting ideas in the future that will be implemented during the next 1-2 years. And so I'm happy to answer questions on this application. Thank you very much.
Great. Thank you very much, Professor Schwitter, for your nice presentation indeed. I would like to comment here that your department has a long tradition and history in this kind of simulations, since my good friend Lucas Kappenberger started organizing simulating computing-based system for arrhythmias, if I remember well, 30 years ago, 40 years ago. Is that true?
Yeah, I think we have quite a huge tradition. So I did a lot of also such analysis with the Federal Institute of Technology in Zurich. And then I moved to Lausanne, and luckily there are only 2 Federal Institutes of Technology in Switzerland. One is in Zurich and one is in Lausanne. So it was not so difficult to make the decision to change to Lausanne. But there is a lot of tradition. Also, just to mention, the first active tracking catheter, the idea of active tracking was invented by an engineer of GE in Zurich, Demoulin, 1993 or so. Yeah. Now we use it every day, but at that time he was ahead of time. So they had a big tradition in such high technology in MR. Yeah.
Yeah, at least from my side, I remember Lucas Kappenberger, Professor Kappenberger, working in arrhythmias and computing for many years. It was since 1995 or even before.
Yeah, he was here, but I was in Zurich, so I had no contact with him. He just moved out when I came in.
Okay.
Yeah.
Yeah,
it would have been fun. It would have been fun to do it together, but I think he left 1 year before I arrived in Zurich, in Lausanne. Yeah.
Great.
But he was very interested in modeling
Yeah, remember,
correct?
yes, he was ahead of his time. He was modeling arrhythmias and computing, etc. Yes. Um, I don't see any questions coming from elsewhere. So, what I would like to comment here is that for sure these simulation models. First, if I would like to comment in general, I would say, starting from your first slides, that I am really very surprised that the interventional cardiology and electrophysiology, etc., everywhere in Europe, but possibly the same in the United States, does not start from the simulating models, but it starts uh, from live cases. We have to be real, very cynically sincere here. Everywhere we used to start our careers, uh, okay, studying beside experienced guys, mentors, but all the times we start our careers in human beings. And for me, still now is the same, more or less. So for me, it's a surprise, a philosophical but also educational surprise. Why is not obligatory by the law? Everyone who is doing invasive attempts, interventional cardiology, electrophysiology, not to start obligatory a period from simulation models.
Yeah.
This is a general comment.
Yeah, I think that's. I would 100% go with you. I think if there are not good simulators, nobody would say in guidelines or position papers you should do that if there are no simulators. Now there is some quite a bit of activity with some simulators, and I think if they improve and electrophysiologists see the advantage of using them, then I think they will benefit and introduce that as a part of training, and also I think as a part of maintenance of skills, because you should also manage complications, but you don't want to have many complications in your patients. But in the simulator you can go to a difficult case and you say, after the third burning, we will introduce a problem and he have to save this patient. So I think there is many things that can be done. Also, we are now working on getting training of the simulator to get the transeptal puncture. I think it is certainly for difficult procedures, it would be nice to have a simulator before you do it in patient.
This is true, and I know that at least in Brussels, one or probably two big well-known companies have developed there the educational centers using a lot of simulation procedures, and they are inviting a lot of persons to be trained in simulation models. But by the law, this is something different. By the law, neither in the United States or in Europe, there is not any need for anybody who is doing one procedure in a human being to be obligatory pre-trained in simulation models, which, in my opinion, should be absolutely reasonable and necessary.
Yeah, yeah, I fully agree. But because
and I have not seen this issue raised by anyone, by the European Society of Cardiology, actually the European Society of Cardiology, but also the UMS should have arisen this legal issue. This is something for further discussion. Talking about,
It was a good paper in, I think it was Europace. It was a questionnaire in Europe. And they asked electrophysiologists what they think about training, how to do it, what is the role of simulators. And they said, I think 80-90% of all the the people that answered the questionnaire of these electrophysiologists, they said it's very important to train on simulators. It will improve the skills. It will improve the capacities of electrophysiologists. And then they ask how many of them have access to a simulator. And then I think it was about 10% or so. So everybody said we should have it, but almost nobody has it. So I think the need is clear. Yeah.
Yeah, the Greek Cardiac Association never asked something like that. I mean, we have to create the legislation. It doesn't exist automatically.
Nowadays, with these existing systems, it's a matter of decision, first for the scientific and professional associations, especially in cardiology, and also in surgery, not so much in other specialties like psychiatry, for example, but in cardiology and in surgery, everywhere blood is involved and possibly high-risk procedures, it should be legally imposed the pre-training in simulation methods. It's really a matter for further discussion.
Yeah.
Yeah. Okay, so now we are 5 o'clock.
Yeah, we have some break. We can do some break before 5:30, which is the next presentation.
So we are coming back in 30 minutes, correct?
Okay, yeah. Well, I think we need it because it was a very intense program.
Yeah, this is
so I will do a little, like 10-15 minutes of showing the simulator in action. I think we have it in the program.
If you can do
in 15:30. No, we have it's 4 o'clock. So 5:30. At 5:30, we would start with a little demonstration of the simulator for 15 minutes or so.
But it is Dr. Lupi.
It's Amalia Lupi's presentation.
Yeah, we have live simulator demonstration. This part here, I prepared a little bit, but not much. Or we could add it now, or we could add it in 15 minutes.
Can you show us right now in 15 minutes or something?
Yeah, I can show it.
Okay, show it right now.
Yeah.
And then we have 15 minutes.